Welcome to the 26th session of Progenesis Academy webinar series. Today's topic is advanced maternal age, when to seek an egg donor. We are very pleased to have three well-known experts in fertility. We have with us Dr. Arnold. She is the founder of California Center for Reproductive Medicine. We have Dr. Sharara. He is the founder of Virginia Center for Reproductive Medicine. And we have Dr. Kalan. He is the co-founder of the Los Angeles Reproductive Center. Thank you so much for joining us.
Thank you.
Very good. Today we're going to be talking about egg donors. So we have a few patients that reach out to us with some written questions, and we may have a live question as well. I'm going to get started with the question on the timing when a physician decide a patient needs to go that route of seeking an egg donor. When do you make that decision or that recommendation? And I will start with you, Dr. Arnold.
Well, there's different reasons or indications for egg donation. One is a woman that would be advanced maternal age into her premenopause or perimenopause years. One that has had several failed IVF cycles. Other indications is someone that has ovarian failure, premature ovarian failure, and or status post oophorectomy for other reasons. I think those are the main indications. Of course, the same-sex couples are the only way that they can conceive.
Thank you so much. Dr. Sharara?
Yes, I would add probably maybe some people who are older or possibly younger with severely diminished ovarian reserve, so that have failed multiple cycles. For example, somebody who is 30, 38, 39 years old, who doesn't make a blastocyst, or if they make a blastocyst, it's a genetically abnormal one. And they've tried 2-3 IVF cycles, and they're basically not making a blastocyst or not making a normal euploid embryo. So indications also have people who have, for example, mosaic Turners or some other genetic anomalies, BRCA1, BRCA2 carriers that do not want to do PGT-M and pass this gene on to their progeny. So the indications over the years have completely expanded. I mean, back in the late 80s, early 90s, there were really women who of advanced reproductive age coming to do this. This has opened up quite a bit at this point. So the use of donor egg is no longer as taboo as it used to be before. And, so the use have really expanded exponentially over the past several years.
Thank you so much.
I think mentioning a genetic carrier is important for those that have some type of genetic disease that we aren't able to perform, the genetic diagnosis, the single gene defect diagnosis prior to implantation with pre-implantation genetics. But I feel that a lot of patients that do have the genetic defect are willing to do the PGT-M, and looking for that genetic defect is when they have a combination of a very poor ovarian reserve or multiple failed cycles, as we both mentioned, or advanced maternal age that, their ovarian reserve is diminished.
Yeah, except that sometimes we have some genetic conditions that are not treatable, like mitochondrial mutations, where a site would be difficult to repair. Very good. Dr. Kalan, what's your perspective?
Yeah, I agree with both my colleagues. I think that they've kind of exhausted the indications. I'll just kind of underline that how it's expanded in the way that we've now, it's now mentioned really as a treatment alternative. Not so much, in the past, I feel like we would have to have truly, failed to a point of just utter devastation for a lot of these patients before they would even bring up egg donation. And now I find myself starting to incorporate it into conversations earlier and earlier, not so much in the sense of trying to, discourage anybody from using their own eggs, but it really is becoming more of a normalized process. And as we kind of think about it in that way, I think it benefits our patients tremendously. So I bring it up earlier than certainly I used to. And I think that by doing that, people sort of are able to kind of process it a little bit more, and understand it, instead of it being sort of like, well, I can't have a family any other way, so I guess I'll do this. It's just like it's a pragmatic tool that we can use to help people build their families.
Yeah, I mean, we've all had these patients that come in and say, "There's no way on earth I would use an egg donor," and they come back 6 months later and say, "I want a kid."
Yeah.
So it, it's going through these, stages of loss. It's a totally understandable process, and at least with egg donation, time is not as critical as it used to be. So if they want to take 6 months or a year to think about it and then proceed with it, that's fine. It's not the end of the world. Versus somebody who's 41 wants to wait another year or two before they try to get pregnant. Obviously, that's a completely different ballgame.
Yeah.
Very good. Dr. Arnold, is it required for an egg donor to take a genetic screening to qualify?
We require our egg donors to undergo genetic screening, the carrier screening, a consult with a geneticist to do a family risk assessment, and a karyotype.
Very good. Dr. Sharara, do you screen those egg
Yeah,
donors?
we do. I mean, we don't do a karyotype, but definitely we have expanded carrier screening quite a bit. I remember, 5-6 years ago, there were, 4 or 5 or 6 genes that we were looking for. Now we look for like 274 different genes, and by next year we could be at 500 or 1,000 within 3-4 years. It's unusual now to have somebody who doesn't have something. But most of these are, I mean, I've discovered donors with cystic fibrosis. I've discovered donors with, many recessive genes that are really not inconsequential. So as I'm pretty sure my two colleagues will say, I mean, in my program, we still recruit our own donors. We nix probably 90% of those who apply. Out of those that make it to the second step, I bring them in, we look at their ovaries, we do all the carrier screen, we do all the STD testing. We want to make sure that we're dealing with somebody who has a decent ovarian reserve, because that's really the key. I mean, these patients are coming to see us because they want the donor to not give them 5-6 eggs. We need a donor that can give them 15, 18, 20, 22 eggs, especially if they're interested in doing genetic testing to not just for gender selection, to make sure that the one embryo we're transferring is genetically normal. So patient acceptance for doing PGTA along with this, I have seen in my practice has increased even with the use of donor egg.
Excellent. Dr. Kalan?
Yeah, we do genetic carrier screening on all of our donors. And even when the intended parent, if they have done a screening already and say they're negative for everything, we'll still do it. Checking for at least CF, SMA, and of course Fragile X, because sometimes we'll find Fragile X or an intermediate Fragile X, and that's a really important piece of information for a intended parent to know about. So we do it on everybody, and like Dr. Sharara was saying, the parents they have the option of choosing certain things at this point. And if they've already been through so much and had so many losses, we want to kind of control as many variables as we can at this point to limit the risk. So we do screening.
And back to the genetic testing components, the X-linked syndromes are one of the most important, factors you would wanted to control for, because if you have a male child, then there is a higher burden, genetically speaking, when it comes to what is the success rate when it comes to egg donors versus younger patients, say under 35, compared to egg donors does the patient benefit from a higher success rate, Dr. Arnold?
Are you referring to an intended parent coming in that's 30 years old versus utilizing an egg donor 30 years old?
Yeah, so if someone, so most of these patients who are seeking egg donation is because they cannot conceive on their own. But once they get enrolled in an egg donation program, they want to know what is their success rate, what's the likelihood of them getting pregnant. Do you guys know what the success rates look like when it comes to egg donors? How high it is, or how likely?
Well, we usually quote, it depends on the quality of the embryo. So as you know, there was a study out of Cornell, the grading using the Gardner system. If the embryo is a high grade embryo, an AA embryo, that embryo has the potential using a single embryo transfer around 70%, which we like to enjoy those success rates. If the embryo is a CC, then it's not fair to tell that patient that they're going to use an egg donation program and have 70%, because we know that CC has a lower implantation. In fact, the study suggested around 30%. So as there's two factors involved with the creation of a blastocyst, one, the egg is an important component, as we know, but also there's a male component. And typically there is advanced maternal age, and sometimes the semen parameters aren't as viable as a younger sperm component would be with a SIP that's 30 years old, using her own egg. But we do enjoy high success rates because typically we will have good grade embryos, but not always. We do a considerable amount of egg donations, and with our first-time donors, sometimes it is a surprise that the egg quality or the amount of embryos that are normal. We perform about 95% or more of our cases with donor eggs. We do in pre-implantation genetics, and we do find that there is a variable. Sometimes we do repetitive egg donation, and we can, with one donor, utilizing the same donor and different sperm source, we see the difference in embryo quality and the amount of normal embryos from pre-implantation genetics, which would be an interesting study to publish. But I think we have to be more than just a number when we talk about egg donation. We have to be realistic and say these are the factors that are potentially involved. Plus, we have the uterine factor, and so the patient who is the recipient, what is her uterine lining like? What is her history of implantation also?
Thank you so much. Dr. Sharara, what's your perspective?
Yeah, I mean, we quote 65 to 70%. That's what our FET rates are at this point. We rarely do fresh transfers anymore. Probably, I'd love to hear what Lori and Mark are saying. Like I said, more and more patients are coming in wanting to do PGTA at this point. So we get the embryos, especially if we have, same-sex couples coming in, they have to wait for a surrogate. And I've been doing surrogacy since 2004, and we used to wait until there's a surrogate, and then we would cycle the donor along with the surrogate then. So now with the wait has gone from 2 to 3 months to find a surrogate to nearly a year, if not more, to find a surrogate. This has completely decoupled. So we make embryos, we freeze them, and then when there's a surrogate, we test, and then we do frozen embryo transfers. Obviously, the chances at a pregnancy with FETs have substantially increased over the past, several years. So we're very comfortable doing vitrification and frozen embryo transfers at this point. So, 95% of what we do is single embryo transfers. With egg donation, it's nearly 100%. Obviously, when we're using surrogates, they all are on chat rooms, and 4 or 5 years ago, we used to transfer 2 routinely. Now it's like very unusual that we would put 2 embryos in a surrogate. Only when they're not PGTA tested and when the quality is not as good. So the grading of the embryos is not, if we have 2 grade, AA embryos that are euploid, we will never transfer 2.
Thank you so much. Dr. Kalan?
Yeah, we're right about 70% as well. You know, I think that's a really fair and accurate result when we're doing transfers with a reasonable grade genetically normal embryo. And us too. I'm doing not. I can't remember last time I did a fresh transfer. It hasn't been. I certainly haven't done one this year. We do the frozen embryo transfers work really well, and I'm up above 90% for PGTA as well. The only time I don't do it is if a patient is really limited in terms of financially and doesn't want to do it. Even in that situation, I encourage someone to do it because I think it actually saves money if we end up having, you know, 10 embryos and 4 or 5 of them maybe employed. Someone can end up doing 2 or 3 transfers and not getting pregnant simply because we're not using the right embryo, and I have no way of really knowing that. Yeah, I usually say 70% for a transfer, but I'll go 70 to 80% for a full cycle. This is assuming you were using fresh donor eggs, because the truth of the matter is, like my colleagues were saying, you know, we're expecting to get 4 to 6 euploid embryos out of a good cycle. And so if God forbid, you know, the first transfer doesn't work, we should have some backups. By that second one, someone's not working, something happens over time. With 4 embryos, we're looking at 2 or 3 kids. If that's what they want.
Yeah, very good. Thank you so much. I think your mic is a little off. If you could.
Oh, I might be too far away.
Perfect.
Sorry.
Perfect.
Actually, it's not nearly as pretty, but I'm going to go into the shade here.
No problem.
There are some differences between the East and the West Coast at this point. The East, you know, we're nowhere near 90 to 95% of PGTA on donor egg, but there's definitely been an uptick. I mean, every year we do more with donor egg than the year before, but we're nowhere near 90% for sure.
Yeah.
We'd like to, but we're nowhere near that.
Yeah. We have some patients that have asked some questions. Miriam have that list of questions. Miriam, would you be able to give us a couple of questions for the physicians to address?
Yeah, sure. So our first patient is 42 years old. She did a treatment in January and it wasn't successful. She said, before I started the treatment, my AMH was 0.9 and I had 7 eggs. I could retrieve 3 eggs, which would fertilize but didn't complete growth. She said that her previous doctor recommended an egg donor. She started another cycle with a new doctor, and then her AMH was 0.09, and then she had only 3 eggs. She requested another blood work, and then after 3 weeks, AMH levels jumped to 0.4. She said the doctor couldn't explain all this variation, and this kind of stopped all hope to retrieve using her own eggs. So she has quite a few questions. I'm going to start off with the first one, and then we can all answer it, and then we can move on to the next. The first question is, do you have any cases similar to mine? In this case, do you recommend searching for an egg donor?
Dr. Arnold?
Well, I always tell my patients that their best option with a low ovarian reserve and an AMH of 0.4, 0.7 is considered a low, very low AMH. I'd also want to see her AFC, which I'm sure would be a low AFC because we look at both ultrasound, antral follicle count, and the AMH. I think that we have to describe to our patients what's the potential probability of her getting a normal embryo from her low AMH and her low response to the stimulatory medications. And so you have to waver that, and you would say, well, maybe it's 15% chance you're going to get a normal embryo versus over 90% chance you will get a normal embryo utilizing an egg donor, which will then have a higher, much higher implantation rate. And I think once a patient realizes the potential success rate with an egg donor, it may or may not be an option. There are some patients that it doesn't matter, even if it's less than 5% probability, they're going to become pregnant. It's their own biological child, and that's important, and that's priceless to these people, and it's not a statistic. So I think we have to individualize each one of our patients and say, okay, really, what are your goals? I'd like you to have a family. The best is with a donor egg to be more efficient and to have your family sooner. But I understand. And so we do have a lot of patients that come with a low ovarian reserve. And we've been seeing these patients for over 10 to 15 years doing embryo banking. And sometimes they only make 1 or 2 embryos, and then they're not normal, so they try another cycle. So we have a lot of experience doing a freeze-all of those embryos and doing genetic studies until they are able to obtain a normal embryo for implantation.
Thank you so much. Dr. Sharara?
So Lori mentioned a very critical point, which is the patient willing to proceed with an egg donation or not? So if she is absolutely adamant about not using an egg donor, we can try. I mean, there's a 15 to 18% chance at having a euploid embryo every time you do this, even if you make 1 blast. The key is, are you making a blastocyst or not? So if you don't make a blast and you do this 1 cycle, second cycle, third cycle, at that point, you really need to stop. The second part of this is the financial situation. So most of our patients have no insurance coverage for this, okay? So doing an IVF cycle and paying thousands, at some point, the cost of medications alone become about 50% of the cost of an IVF cycle because they're requiring so much medications. So the question gets, if there's a small, and that's exactly the wording I use with my patients. If you have a pot of money that you have on the side, and if you use that pot of money and you don't have any embryos to transfer, that money is gone. If using an egg donor is acceptable to you, I will tell you, please use an egg donor that not only has a substantially higher chance at getting you pregnant, you will have extra embryos, hopefully for baby number 2 or 3 or 4 or whatever it is. So there's not just the acceptance, the financial situation is really critical at that point. And whether an AMH of 0.4 or 0.1 is really not going to make that much of a difference. If you're making 3 eggs, you probably antral follicle count is only about 3 in both ovaries. And that's a very, very poor ovarian reserve at that point.
Thank you so much. Dr. Kalan?
Yeah, I agree. I mean, I think that a couple of things. So one, at this point, I don't know if there's any purpose in checking an AMH again and again. The truth of the matter is the ovarian reserve is low, and if the AMH came back at 0.03, or if it jumped up to 0.9 or came to 1, it doesn't really change anything. The truth is the ovarian reserve is very, very diminished. She's now been through 2 cycles without creating any blasts. I think that it's really important to use numbers, say 15%. I might even quote a lower 10 to 15%. It could even be single digits. And be very frank with the patient in a sensitive way, of course. I mean, not in a way to scare anybody, but be very transparent. And then let them know what the difference is between that, and then gently introduce the option of an egg donor as a different possibility, and again, normalize it. Maybe this is a patient who's even heard about it in the past. And as long as you can really communicate with the patient and make sure that they understand what their chances are with their own eggs and what their chances are with a donor egg, and then they can make a choice. And if they choose, you know what, I want to try with my own eggs, well then fantastic. Then the AMH doesn't matter anymore. The donor egg success rate doesn't matter anymore. We're going to do everything we possibly can to try with your own eggs. But we also can keep in the back of mind, if this doesn't work and we've sort of exhausted everything, maybe that's something else we can move on into the future. Of course, there's the money part of this, which is a huge aspect to it, and we can't ignore it. But ultimately, I think giving the patient those tools and then executing them in whichever direction they choose is sort of our job.
And for those patients who only have 1 or 2 embryos, would you test them genetically if that's all they have? Or would you go with the transfer directly?
So this is the big debate in the literature right now. I mean, you have people who come and tell you look, you shouldn't test 1 or 2 embryos, try to put them in. It's somebody who's 42, I highly recommend they get them tested, because we don't want these patients to have a miscarriage, or worse, get pregnant with a Down syndrome baby that they would have to go and terminate around 11, 12 weeks. That's absolutely brutal. So I'm all for PGTA testing for these patients. Even if they make 1 blastocyst, I would highly recommend for that blast to be tested.
Very good. Dr. Arnold, what's your perspective on this?
Oh, I totally agree. I think that it's a shame to waste reproductive time if you transfer into a 42-year-old an aneuploid. And even if she has an early miscarriage, it's still wasting time, her reproductive time, if she's going to utilize her own eggs. But not even just that, just the emotion, and also the effect on the uterus and the potential risk to the uterus. So I think that I strongly recommend that our patients do testing, regardless if they only have 1 or 2 embryos.
I mean, the biggest positive for PGTA has really been the substantial decrease in miscarriages that we're seeing. And this is brutal for any woman who's gone through a miscarriage. It's an absolutely brutal thing to go through. And what Lori said, this 2 to 3 months of time wasted is really critical if you're 40, 41, 42. But more than that, it's the psychological destruction of dealing with a miscarriage or having to terminate a genetically abnormal pregnancy.
I totally agree with you.
Yeah, I'm on the same page. I'm all for it. I mean, as I was saying, we test so much. The other part that I'll add in there is just, a lot of this is about making the right decision for patients, and that information is incredibly valuable. If we make a beautiful blastocyst, we don't test it and we put it in and it doesn't work. Now we've introduced a bunch more questions. Should I keep on doing this? If we've tested it and it's not euploid, then we know what the answer is, and the patient's able to make some smarter decisions with accurate information. So for all those reasons, I'm 100% in favor of testing them all as well.
I mean, we all have had patients who you tell them to test and they refuse to test, and that's fine. That's their call. Okay, so they deal with basically the emotional burden if we do a transfer and they don't get pregnant. But I've had 42 years old refuse to test their embryos, 1 blast, put them in, and they have a live birth. It happens. 18%, 15 to 18% of these embryos are genetically normal. These people hit the jackpot. It's perfectly fine.
Yeah. Very good. Before we move into the next question, Miriam has that list. We have had many times patients asking why my AMH is fluctuating so much. What kind of response would you guys give them to kind of explain the variability between tests and all these things? Not necessarily AMH going down with age, it's just that fluctuation within a month or stuff like that.
So multiple things. First, are you testing at the same lab? That's one. If they go to LabCorp and has a value, they go to Quest, they get a different value. They go to another lab, they may have a different value. Most of these are going to be pretty close to that thing. So if you have, that's why I would tell you the 3 of us will look at AFC as the antral follicle count, and at least in the US docs, all of us look at the antral follicle count much, much closer than the AMH. We've always had AMH levels that don't make any sense. You do an ultrasound and you see 3 antral follicles and you get an AMH of 1.5. One of them is wrong, and it's definitely the AMH, okay? I mean, we've been doing ultrasounds for a long, long time for us to know that when we see an antral follicle count of 3 versus an antral follicle count of 10 or 12 or 15. We're not gonna make that mistake. And then, there were issues with the AMH assays before, they fixed that before. But again, always, AMH, FSH, AFC, all of these are quantitative markers. They tell us the quantity. They don't tell us anything about the quality. The quality is really age related. So as Mark said, if you get one that's undetectable and then you get one that's 0.4, they're both still very low. Okay, so they're not going to jump from somebody has an AMH of 0.4 and you do it in a month or two and now it's 1.5. It just doesn't happen. It's like age. None of us is getting younger except Lori, but that's a different story. But the AMH is exactly the same way. With time, it will only keep going down. And it's a snapshot in time, like FSH levels. The issue, AMH go down way before the FSH starts going up. So that's why an AMH is a better marker for ovarian reserve. But we all have to look at the big picture. We look at age, enteral follicle count, AMH, FSH to make a decision what we really need to do.
Thank you so much. Any other comments on AMH variability?
I guess the only other thing is, you know, I think that when we first started using it, it was thought of as like this holy grail. There's this unchangeable number that was really quite useful. And I think over time we've realized it's been less and less so. Although I you know, anecdotally, and there is some evidence about this, the use of like Depo-Provera, birth control pills does have some effect on it. So that could be another thing.
Very good. Miriam, would you like to get to the next question?
Sure. So we have follow-up questions from the same patient. So her next question is, if the patient chooses to use a donor, would you recommend fresh or frozen? And then what is the success rate of fresh and frozen?
So Arnold?
Fresh or frozen embryo transfer or eggs?
No, eggs.
Eggs.
Okay. So we perform mainly fresh retrievals, and that being one, for the amount of eggs that we obtain, we feel that our fertilization rate is higher, and we are able to freeze embryos at the blastocyst stage, perform genetic studies, and then the patient knows how many normal embryos that she has, or the intended parents have to work with. When you only freeze eggs, honestly, you don't know the end result, how many embryos, and we have more experience, many years, over 30 years of freezing embryos than we do with egg freezing. So I feel that it's more secure to freeze embryos than oocytes from an egg donor. Given that information, that works very well for our program. But again, now we know the methodologies for freezing eggs. The vitrification of the oocytes is better than it was years ago. And I know that there are programs that freeze the eggs for the egg donors. In fact, they distribute maybe one collection of egg retrieval to several intended parents. I don't necessarily believe in that. I believe that the intended parents should have access to all of the egg donation at that time. And so therefore it increases their chances of one having more embryos in case the first transfer doesn't work, but also for other siblings in the future with the same egg donor versus just selling 6 1/2 dozen eggs when typically a donor will give 20, 25 eggs. Also, you don't know if those eggs that they're giving to the intended parent are viable. Maybe those are the eggs that aren't going to make it to blastocyst stage. So we have a fresh program in a sense of collection and then freezing those embryos. We've been doing a freeze-all genetic studies for many years. And so that's our protocol, although once occasionally we'll do fresh transfers. And we're very successful at fresh transfers. It's just the turnaround for genetic studies on those embryos. Sometimes there are delays for the transfer, especially if those embryos are day 6. It's difficult to have that embryo stay until day 7 and without fear of losing the viability of that embryo while you're waiting for genetic study results.
Thank you so much. Dr. Sharara?
So, I mean, the question of using an egg bank versus using a fresh donor is really, I mean, I get asked this all the time. I mean, Lori touched on this, but in egg banks, they get this egg donor and they blast them with medications. They want to get 30, 40, 50 eggs, whatever it is, because the more eggs they sell, the more money this egg bank is going to make. And when you go buy 6 eggs, if you're lucky, you may get 2 blastocysts from these, versus in a fresh cycle. And I still believe fresh eggs give a higher chance of a pregnancy. And there's data already published on this. There's a JAMA article from about 3 years ago. If you look at the SART database for frozen eggs versus fresh eggs, frozen eggs are about 15% lower in terms of pregnancy compared to fresh eggs. And Lori touched on a very important point. If this couple want to have more children, more bio-siblings, so basically biologically identical siblings, if they buy 6 eggs from an egg bank and they go back 2 years later, that bank may not have any eggs left, and now they have to go buy eggs from a completely different donor, and therefore they're going to have siblings that are not really related, not as related. They'll be half siblings that really not going to be, full siblings. So if you're planning, you have a child at home and you only want to have another one, and you'd rather buy 6 eggs with the hope that you will have 1 child from this, that's okay. But it all depends how many kids you would like to have. And also, buying eggs from an egg bank, the more eggs you buy, the higher the cost. And at one point, it becomes substantially more than getting a dedicated donor that's going to give you 18 or 20 or 22 eggs. 1. 2, we don't know which egg is the one that's going to make a euploid blastocyst or a normal embryo. When you go buy 6 eggs and this donor has made 40, what if none of these 6 eggs were destined to produce a child? So you're really taking that, you have to take that into account.
Thank you so much. Dr. Kalan?
Yeah, I much prefer fresh eggs. And I see there's 2 advantages to using frozen donor eggs. One, it's faster, and that's really attractive to some people because you can get them tomorrow if you want. And 2, the absolute cost for 1 cycle is a little bit lower. But
depends how many eggs buy. Depends how many eggs they buy.
Well, yeah, that's the point, is that on a per egg basis, it's definitely more expensive. It might be $14,000 for 6 eggs, whereas it might be $20,000 for 20 eggs. It's considerably, for 30 eggs. So if it was me and my wife, or me and my husband, or whatever it may be, I would certainly try and spend a little extra money and spend a little bit more time to get a fresh. The other part of having a fresh donor is, it is such an emotional decision on how you're choosing a donor. And I see part of our roles is being the liaison for our patients in meeting this donor, interviewing her, and making sure that she is kind of as advertised. Most of the egg donor agencies out there are reputable and great, but the truth is that they don't have the same responsibility to the patients that we do. We are their doctors.
They're in the business of making money.
Yes, they are businesses. We are doctors, and I'd like to think that we are held to a higher standard for that reason. And so, the egg donor, she may be beautiful, she may have amazing pictures, but she comes in and she's got an eye patch and a peg leg and a tattoo across her neck. I want the IPs to know that. So with a frozen donor eggs, you don't know.
So exactly what I tell my patients, I'm your eyes and ears, okay? So I put myself in your shoes. If I want to use a donor, would I use this donor or not? So we're really their eyes and ears. But so I see a role for frozen eggs. If somebody comes and tell me, look, I want somebody who went to Stanford undergrad and Harvard Law School, then I'm going to tell them, we don't have these patients and these donors in my practice, okay? You can go and buy what you want. The other thing, we have some people who come and tell me, look, I want a donor who's 1/4 Thai, 1/4 Jamaican, 1/4 American Indian, and 1/4 French. We're not going to find these people for them. So we tell them, okay, go look at egg banks. And if you find somebody like this, by all means, you can buy these eggs at that point. So it all depends what they're looking for. Most of us bring donors that are, we're interested in not just their ovarian reserve, exactly how they look, we all have dealt with donors that lie on their applications, okay, just to come in, and we bring them in. And this is when exactly what Mark was saying, we find it sometimes, rarely though, but every now and then, somebody who is completely different than the application they filled.
Yeah.
And so are you saying that some of that may be somehow genetically inherited, some of the characters, or what's the if you're looking at an egg and you look at the character of a person, give me that connection that you're trying to.
But remember, I mean, most of these donors are doing it because there's money involved, okay? And there are donors who, even though we're supposed to use a donor a maximum of 7 dimes according to ASRM, there are these donors that fly from state to state, and they donate at different egg banks or different programs. So, when you sit down and talk to an egg donor, you will find out, are you dealing with somebody who's really professional, or they really haven't, done it? Most of our donors donate maybe 1 to 3 times. They rarely donate seven cycles. So you really, when you talk to these donors, you find out who's lying to you, who's pretty manipulative, and those are completely nixed immediately.
Yeah.
Your question.
Yeah.
I think that the importance is a couple of things. So one is this is a good example. I had a patient who chose a donor, and her pictures are beautiful, and she came in, and one thing just struck me is that her hair was much thinner than I noticed in the pictures. And I talked to her about it, and in her pictures, it turns out she'd been wearing a wig in every single one of her pictures. So I don't know if it's a wig or extensions. I don't know too much about hair on your head, but whatever it was, the thickness of her hair was not as it appeared. And that turns out to be something that was very important to my patient. And they realized, I mean, that it's not like there's a specific gene that this donor may have that may exactly pass on to the thickness of her hair, but we know that there is this genetic component. We don't know exactly how it all manifests itself in a child, but I think we owe it to the patient that if she is choosing this, if that's one of the qualities that she is looking for in her donor, knowing that it may or may not pass on directly, she should at least have there should at least be, she should know whether that is an accurate representation of what this girl looks like or not. And that's what we can provide her.
Very good. Thank you so much. Dr. Arnold, one question on InvoCell. We got this question from a patient that was asking whether using InvoCell in some ways will enhance the outcome in a donor.
I'm sorry, I can't hear you, the connection.
Yeah, so one of the patients asked about InvoCell, the device that you guys use for incubation of the embryos, whether that enhances in some way the outcome, the clinical outcome, or it doesn't matter.
In our clinic, we don't utilize it. So I'll pass that on to somebody that has experience.
Sure.
I mean, I've done a couple of cycles of this. This is definitely, I mean, in the InvoCell, you'd like not to put more than 8 eggs in there, and you don't check for fertilization. So you put 8 eggs, you put the sperm, you bring the patient 5 days later, you put this InvoCell in the vagina, you bring them 5 days later, you have no idea what you're going to find. Okay, sometimes you may get 1 blastocyst, sometimes you may get absolutely nothing. I mean, InvoCell is fine as a step between IUI and IVF. Yeah. Definitely not when you're going with something as expensive and as emotionally, involved as using an egg donor. So I would definitely not recommend looking at InvoCell in that particular situation. Mark, do you agree?
Yeah, I have no, I mean, I've read about it and I've talked to people about it. I have no personal experience with it, but egg donation works so well. I would see InvoCell as a risk, kind of like how Dr. Sharara was saying. I can't imagine putting these really incredibly valuable eggs. Yeah. Even just from the concept of like storing it in the vagina, like embryos are never supposed to be in a vagina anyway. I don't understand. I mean, it seems crazy to me. You might as well put it in your armpit, I think. It seems like a crazy thing to do.
It works for some people. Some people have really a very hard time, growing embryos in vitro. So there are patients with certain religious beliefs that, believe life starts, at the moment of fertilization, and they don't want to make sure this is happening in the lab. They'd rather feel that it's done inside of them, even in a capsule in the vagina. That's perfectly fine. But I think the detriment in this case is way, way, way overwhelms the benefit.
Very good. Thank you so much. I think we have another question from that. Miriam, can you read that question for us?
Yeah, I know we kind of touched on this a little bit, but she asks, what information can a patient get about their egg donor?
Yes, so that's what we have been discussing so far, right? So any other information a patient need to know about the egg donor?
Well, that's specific. So we have, and I'm sure Lori and Mark do the same thing. We have them fill a 28-page questionnaire. So we give the patient 25 pages of this that have the personal history, the family history, genetic history, all these things. So any non-identifying information, we actually give this to the patient if she uses that donor.
Dr. Arnold?
I agree. We have extensive H&P. We also, as I mentioned earlier, obtain a genetic health risk assessment for the family, and that's done by a professional geneticist. So we give a copy of this to the intended parents so they have for their child any potential ongoing or diseases that could happen in the donor's family, so they're aware of it, and that is actually given to them prior to choosing or selecting their egg donor. They also are told about their psychological screening and their prior donations, their prior fertilization and pre-implantation genetic results with prior donations. So they're making an informed decision on not only their H&P and, but most importantly, their genetic history. And California, we just have a recent law that's passed this year that actually gives the intended parents a choice whether or not their child at 18 years old may contact the egg donor. And so now we are obliged to give that information to our intended parents if the egg donor will be compliant and yes, will agree. She has also the choice to disagree and not to have contact. But that's part of also information that is important to some of our intended parents.
Yeah, and that goes to the point of Dr. Kalan that you have to really choose the right donor, because and he is based in California, so at some point you may have a child that wanted to see their biological parents. Any other comments, Dr. Kalan, about the right of the patients of knowing more about the donor and how much they need to know?
Yeah, I mean, I agree with my colleagues. I think that, we've really moved to an era of transparency. Everything we can, short of identifying the donor, we provide that to the patients. I think it's important. There's some things that can be scary, but ultimately, I think that it's important that they know as much as possible. And that's another thing. The donors need to be aware of that as well. There's some counseling that we need to provide for them. The process is done anonymously, but as Dr. Arnold was saying, there's a point at which I may hold the information anonymously, but whether it's legal or not legal in this world, if somebody wants to find someone, they can do it pretty well. We're providing non-identifying information, but a quick Google search of, I mean, you can search an image and find someone. So, the idea that these are anonymous is somewhat laughable.
So one of the things, we don't allow them to take pictures of the, I mean, we have recent pictures of the donors, not baby picture or whatever, but we do not allow the patients to take a picture of this because of exactly that specific point. That said, what's going on now with Ancestry and 23andMe, whatever, probably 5 years from now, everybody is going to know. I mean, you know, when the baby is born, they can run a Ancestry test and they can, you know, hit matches on the donors. So the more people do this test, the more this net, you know, is thrown out, the easier it is ultimately for people to find their donors. And this is really the scary part, because our patients are doing this anonymously. They do not consider this child theirs. It's like, for women, this is a sisterhood. Okay, so I'm helping a couple in need, but I don't want to know that there's a kid out there. And we don't tell them. We don't tell our donors if they ever produced a pregnancy or not. And I've been doing this, you know, for over 26 years, and I've had 2 donors ask me if their donation led to a pregnancy. Only 2, and I tell them we will not tell you, but they know from the beginning when they come in, they want to do it anonymously. This is not a child as far as they're concerned.
I agree with you. And the question that Nabel asked was, what are we to tell our intended parents? But also, according to ASRM's guidelines for repetitive donation, we have to inform our egg donors that this may not be anonymous donation, especially because of these genetic companies, that the children can track them. So I think it's important that both parties know that this may not be anonymous. I think in the future, there's going to be more tracking of donation, and it'll be more known, or as we know from the FDA terminology, direct donation. And so that's what we're looking at right now in California. It is an option, but our donors now have that option if they want to be traced or not. But they do have to realize that this may not be an anonymous process.
Well, I don't know if you guys read this article in the Washington Post, I think about 2 weeks ago, on a sperm donor who 39 children have actually traced him. So
I read that, yes.
It's a disaster. You know, for a sperm donor, it's a different story. For men, it's much easier to donate a sample. Going through an egg retrieval, no donor is going to go through 39 egg donations. I will guarantee you this. But even if they do 7 cycles across the country, and they're making, you know, 18, 20 eggs, and these eggs are being, you know, from an egg bank, they're sold to, you know, so many couples. That's how this process can really go exponential at this point. So there's everybody who does this will have to assume that there is absolutely no, and you know, it's not anonymous anymore. Okay, we have, you know, so everything is open up. There's no privacy anymore.
Yeah, very interesting. From a scientific perspective, is there any future for science to address a chromosome abnormality in older patients and repair some of that genetic, you know, defects in meiosis or other, or maybe stem cell? What do you guys see the future as far as, you know, addressing infertility for those patients who wanted to have your own kids?
I mean, there was a paper that was published in Science, I think last year, in mice, where they were able to create stem cells that they basically, to make eggs all over again. So there's work in both women, you know, not women, but basically females and males. It's all in the mice or rat stage at this point. It may take another 10 years to do this. We do not know. But I predict at some point in the future, making eggs would probably be a reality.
Yeah, even from sperm.
Right, that's what I said, for both females and males. Yeah. So making sperms, it is probably easier than making eggs. I mean, the egg is it's probably one of the most complex cells that are out there. Sperms are just like men; they're not as complex. regardless of what most women would say. But most men are really not that complex. But the egg is an incredible apparatus. Remember, when fertilization happens, you take that sperm head that has a DNA, but everything else is the egg. So what gets the embryo to start dividing for the first 3 cells is 3 days is all driven by the egg. So the egg is extremely complex cell. But you know, if you came and told me, I mean, I was around when the early days of IVF, when the pregnancy rate was below 20%. And I remember in 91, I was interviewing for fellowship at Cornell when Zev Rosenwax went there. And he told me we're going to get to 50%, and my jaw dropped. Okay. So I never thought we would see 50%. We're routinely getting close to about 70% right now with a single embryo transfer. Would we ever get to 100%? I really doubt it, because there's so many other things that are involved. But if any of the audience have seen this movie called Gattaca, it just, you know, this is where the future is going.
Yeah. The other thing I'll mention is just the, you know, the effort and the work in the mitochondrial work. You know, it seems like transferring mitochondria or somehow regenerating the energy of the mitochondria will have stupendous effects on the egg. It seems like that's where really a lot of the source of the errors that occur that limit human reproduction. So I mean, I'm certainly not a molecular biologist or anything like that, but the mitochondria is really where a lot of the future lies.
Yeah. So to your point, Mark, there was a paper in Cell in February this year in mice. You know, you probably all know who David Sinclair is, but this is probably the most eminent, you know, aging researcher. He's Australian who works at Harvard. He also have a lab in Australia. But he got mice that were basically menopausal, and he used a compound called NMN and got to have some of these mice make new pups. So there's a lot of research on this, and that's specifically on the mitochondria at this point. So this NMN, it's like, you know, CoQ10, but on steroids, it seems. But again, this is one paper in Cell looking at a mouse model. So you shouldn't really jump into and start taking it, assuming it's going to be the same thing for humans. But there's a lot of research going on. The sad part is for our patients right now, this is all we have available for them. We can't tell somebody, well, wait 10 years, you may be able to get you new eggs that you can form. These couples want to have children now, and this is what we have to offer.
Exactly. Would the 3 parents IVF be an alternative to that mitochondrial replacement and the cytoplasm and all these elements that really?
Well, this is illegal, Nabil. So there's the mitochondrial injection work that happened in you know, in I think the mid 90s, you know, with Jacques Cohen, whatever. So they did this on, I think, about 21 patients, and the FDA came in and completely shut it down. You're making a person with, you know, 3 genetic components now. Yeah. So you have mitochondria from the patient, you have mitochondria from the donor, so they came in and completely stopped that. So in the US, it's illegal to do mitochondrial transfer.
Yeah.
That's why John Zhang went to Mexico City to do this, and he got, you know, into major trouble in the US because of this.
Yeah.
There was a baby born a few years ago in Canada in which they used the mitochondria. But as we know, the mitochondria has its own DNA. So then you're having 2 different types of DNA.
But there's a research project. So they allowed it from a research point of view in the UK right now. So they are doing this in the UK, but strictly under research protocols. In the US, it's illegal.
Yeah. Fascinating. Very good. Well, we're coming to the end of the webinar. I would like to give you guys a couple of minutes to introduce your practice and tell us what you do for patients. And I will start with you, Dr. Arnold.
I'm the medical director of California Center of Reproductive Medicine. We specialize in egg donation, and we have a physician-led surrogacy program to help our patients conceive through third-party reproduction. And we also specialize in the pre-implantation genetic diagnosis here in San Diego.
Thank you so much. Thank you. Dr. Sharara?
So I'm the medical director and founder of Virginia Center for Reproductive Medicine. It's a boutique practice in the Washington, D.C. area. And we do all aspects of fertility treatments, IUI, IVF, genetic testing, surrogacy, donor egg, embryo adoption. I mean, we do everything.
Thank you so much. Dr. Kalan?
Yeah, I'm Marc Kalan. My practice, it's called Los Angeles Reproductive Center. It's myself and a partner, and it's a wonderful practice in northern Los Angeles, and we specialize in taking really good care of our patients. And so, depending on what treatment they require, we'll do that. We do a lot of IVF. We do a lot of third-party reproduction, including egg donation and surrogacy, as many practices do. We do IUIs, a little bit of tubal surgery as well. We'll put back some bilateral tubal ligations, re-anastomose the tubes. But it's really focused on doing the right thing for the patient at the right time. And you know, the field of reproductive medicine, as you can see from my colleagues here, it's a pretty evened out field at this point. And if you keep up with the literature and you do a good job and you take care of your patients, we all enjoy really amazing success rates that even 10, 15, certainly 20 years ago, no one would have imagined. So yeah, that's what we're all doing.
Thank you so much. Well, with this, we are coming to the end of the webinar. I would like to extend my gratitude and appreciation for for what you do for patients and your dedication. Next week on Wednesday, 3 p.m. Pacific time, we will have a special session in memory of Justice Ruth of the Supreme Court, and we're going to invite some entrepreneurs, females that have impacted IVF in the US. So stay tuned, check your email, and I will see you next week. And thank you so much for joining us.
Thank you very much for inviting us.
Thank
you for having us. It's a wonderful platform. Really appreciate it.
Thank you so much. Thank you.
Thank you for the opportunity.
Thank you.